Hey, this is the second section on blood pressures, and just rehearsing what we did in session one. We looked at things like the preload, the contractility, and the afterloads, which are determinants of the stroke volume. So cardiac output is the amount of blood that's pumped out with each contraction of a ventricle, on average 70 mils, and you multiply it by the heart rate. So if the heart rate is 70, stroke volume is on average 70, you get 70 times 70 is 4,900, so about 5 liters of blood. The average person also has probably around 5 liters of blood. So in 1 minute, all of that blood gets circulated. So we looked at the analogy of a water tank with a pump attached, and then have an irrigation system with nozzles or sprinklers here. And then we looked at if you tighten the nozzle, make the diameter of the sprinkler smaller, then you get a nice good spray of water. And that's a bit analogy with the blood system, where if the pump is the heart and you have the aorta and then the arteries and eventually arterioles, then if the arterioles constrict, that's called vasoconstriction, then you get a good spray of blood afterwards, but the pressure in the arteries before that will go up. So that was called the afterload, also called systemic vascular resistance. And the chemicals that affect this vasoconstriction can also be called vasopressors. In particular, when we look at drugs later, vasopressors are particular drugs that can increase the blood pressure through vasoconstrictions of the arterioles. Of course, if the afterload goes up, then the heart has to work harder to pump against that load. So the contractility of the heart, that's also called inotropy. So there were certain drugs who were positive inotropes. That means they make the heart stronger. Those positive inotrope drugs, such as noradrenaline, usually have to be given with a central line, because they're very short active, but also a very dangerous drug, so to say. They have really strong effects. So we're looking at an ICU setting, really. Then also we looked at what is called the preload. So we looked at the tank, that's the pool of venous blood. If the tank is low, or if there's a low amount of venous blood because there's been some form of blood loss or fluid loss, dehydration, vomiting, diarrhea, or even things like ascites, then the tank is filled on a low level, less blood is returned to the heart, and then the stretch on the myocardium was called preload. So a little bit of blood going into the ventricles, if we compare it with an elastic band, gives a little stretch and not much oomph to the stroke. If the heart is filled fully, then of course there's more stretch and the stroke will have lots of oomph. And last but not least, if the myocardium is overstretched, it will start to decompensate. And that particular relationship is expressed on this graph here. So just going back here to the tank, we have the preload. So normally if the people are hypotensive, we will raise their legs. The legs are said to have about 400 mils of venous blood pooled in them. So by raising it, gravity will start returning that blood, the tank starts filling up, and our preload will increase. And of course we can also give IV fluids. So IV fluids can go through peripheral cannula. If you have to have large amounts, and of course you need to put large bore cannulas in, often in the precubital fossa, or you need a central line, which is even better. So let's just look at that relationship of the stroke volume and the preload. So there's a famous Frank Starling curve. I call this fluid responsiveness. So we want to look if we bolus fluid or we raise the legs, and we increase the preload, how is that affecting a change in stroke volume? So delta stroke volume means the stroke volume variation. So the stroke volume, say, is 70. Now we increase in the preload. Will it increase by 10 to maybe 80, or maybe increase by 20 to 90? So when the tank is empty, of course, there's no stroke volume. And then if you start loading up your tank, you see that the stroke volume starts increasing really rapidly. But there will come a point where giving more fluids in your venous pool, preloading more, where the stroke volume will no longer increase, and actually the curve will go down if you keep increasing the preload, and eventually you get a decompensation of the heart and maybe heart failure in the end. So that's usually seen when you have malignant hypertension. So you see here the afterload. So if the afterload is persistently high, the heart has to start working really hard. You preload it, the stroke volume goes up, but there comes a moment where the heart decompensates and there is heart failure. So if you ever see the Frank Starling curve, that's what is indicated. So what that means is we cannot always give more and more and more fluid to adjust the blood pressure to what we think is a reasonable blood pressure for that particular patient. So what is a reasonable blood pressure? Well, for that I have this third graph here, and see on the vertical axis blood flow, and on the horizontal axis we have mean arterial pressures, or MAP. So what is the situation here? If you look at this graph, you see that if there's no pressure at all, I have no blood pressure. Then if my mean pressure goes up, my blood flow goes up. But then there comes a point where if I increase my mean pressure, my blood flow remains the same up to really high mean pressure of 160, 180, and then it goes up again. And that process is called autoregulation. And what that means is in certain organs, particularly the brain and the heart and the kidneys, the blood vessels will constrict or dilate in response to changes in the blood pressure to maintain a just equal flow. So if we go back to the first one here with the afterload, so the arterials will adjust so that although the blood pressures change, my flow remains the same. So which organs do this, and what exactly is the mean arterial pressure? The mean arterial pressure is a simple formula. Basically, you take the systolic pressure, then you double the diastolic pressure, add them together and divide by 3. So say you have 120 over 80, then it will be 120 plus 2 times 80 is 160, 120 and 160 is 280, divided by 3 is about 93, 94. Some of the monitors will just deviate slightly from that, but roughly that's the mean pressure. Okay, so which organs then are the ones that are involved with autoregulations? Well, we're looking always at the organs which are called of hyperfusion, and which are dependent on a continuous supply of glucose and oxygen because there's no energy stores. So these organs are the brain, the heart, and the kidneys. So some people ask me, why not the lungs? Well, the lungs are actually not performing any labor themselves. It is the midriff and intercostal muscles who perform the labor of breathing. So they expand the chest and then later compress the chest. And so the lungs have nothing to do with that. They just follow suit. So really low energy requirements for the lung parenchyma and airways themselves. And then some people say, well, what about the liver? Well, the liver has lots of energy stored in the way of glycogen, so it can do with relatively low blood flow, and particularly if you're not digesting any food, then your liver is usually not very active. So that all being said, the brain and the heart and the kidneys have no energy reserves. They are dependent on a continuous supply of glucose and oxygen, and the way the body has designed it, that it maintains an equal flow within certain parameters of these mean pressures. So we're looking at hypotensive patients that had fluid loss for one reason or the other, and now we want to make sure that we tune them up with IV fluids, possibly vasopressors that can be given peripherally initially. So we're thinking then of things of phenylephrine in obstetrics, but also things like aramine or metronidazole, which is the same thing. One is the brand name, the other is generic name. Also ephedrine. Ephedrine then also is a positive inotropes, and even we need drugs that are stronger. We're looking then at noradrenaline, dobutamine, those kind of drugs, and they need to be given through a central line. So I'm going to leave them alone. So back to this picture here. So depending which textbook you read and which intensivist or doctor you work with, you'll see then you have a certain goal to keep the mean pressure over 65 or higher, or maybe 70 or sometimes 80. So I've seen anesthetists who interoperatively set a goal of mean pressures of 80 or higher. But also I've spoken to intensivists in the ICU, and depending which organ they are worried about, they sometimes set a mean pressure of 65 or higher, or 70 or higher, depending whether they're worried about the heart, or perhaps the kidneys, or maybe even the brain. So as nurses, when we look after patients that are on vasopressors and on fluid resuscitation, one thing to remember is that you would probably want to have an art line in place and just a 3-lead ECG, so you can monitor for arrhythmias, possible ischemia, or even worse in the myocardium. And also with the art line, you have continuous readout of the mean pressure, and you can see if the therapy maintains a good level for the blood pressure, ensuring good blood flow, in particular these critical organs, the brain, the heart, and the kidneys.